Hello, dear colleagues, dear President. It is an opportunity to talk about this new tool to reduce angina. Let me show you this case. It is one of my patients. I'm following this patient since 30 years, and his patient is right now symptomatic. And he have a huge history of coronary artery disease, beginning with MI, inferior MI. Then we did a 3-vessel PCI. He had also restenosis process, so he had a CABG, 2-vessel disease. And then we did another PCI because it was again symptomatic. So this patient is right now symptomatic with the optimal medical treatment. You can see the treatment is on atrial fibrillation and treated for that. His left ventricular function is very good, and he had ischemia on the inferior wall detected by scintigraphy. You can see here his left system with a huge area of stents. We have a circumflex which is not really diseased, but the LAD is completely occluded. And we have here another view of the left system. Here the right coronary artery, which is occluded also, and the lima, which is good with no significant coronary artery narrowing inside. So, symptomatic patient with optimal medical therapy, no further revascularization options, so reducer was a good indication for me for that patient. So 3 steps to perform this reducer. First of all, it is very important to optimize the cath lab, and we will see that, the cath lab setup, and the access to the sinus to be sure that we are able to do this implantation of the device and then implant the device in the coronary sinus. So the patient is positioned like in a daily practice, but the operators at the head of the patient at the table, the scrub table also is at the head. It is very useful to perform also the puncture of the jugular vein with the ultrasound. And the screen is at the foot of the patient. That's very important to well install all the tools for the procedures. That's very, very important. Then we perform the puncture of the jugular vein with ultrasound guided. We put the first sheet, which is a 6 French sheet, and then we oversize with the 9 French sheet. The first step is to measure the pressure of the right atrial pressure. This pressure must be less than 15 millimeter of mercury. In this patient, it was 4, so no problem for that. Then we engage with a multi-purpose, and sometimes it is not possible with the multi-purpose 6 French. You can use the Implant catheter, and then make a good opacification of the sinus to be able to measure all the sinus. And the diameter which allows the implantation of the sinus must be less than 13 millimeters of diameter. In this case, it was 11, so it was okay for that. You have to also choose the landing zone for your device. The perfect landing zone is when you have a valve just after the angulation and before the distal branch of the sinus. Then you use the telescopic technique to introduce with the wire, 35 wire, to introduce your delivery sheet, which is 9 French delivery sheets, and you go very fast in sinus, and then make a good opacification and choose the good area to put your device. Here we can clearly see that we are in the good area to do that. Then you inflate your device, your balloon, 4 to 6 atmosphere, and to oversize a little bit your device, 10 to 20% oversizing regarding the diameter of your coronary sinus. Then you remove the balloon very gently, and you deflate a lot your balloon to be sure that you will not move the stent. And it is very easy to do, but you have to do it very gently and carefully. So the plan was to prepare the setup, the cath lab very well, which is very important. The access to the coronary sinus, and to perform a good angiography of the coronary sinus, first to be sure that we are able to put this device, and to find the good area to put this device, and then deliver this device. It is really easy to do, but we have to do it very gently. So with this patient, it was a war of 30 years. So now the patient is still asymptomatic, and I hope that it will be symptomatic for the rest of his life. Thank you very much.
Thank you, Hakim. Yes, a question. Go to the micro, please. It's important.
Hello, thank you for this fantastic presentation. I have a couple of questions, if you please. First of all, did you get any consultation from a CTO operator? Because you said there was no revascularization option. We have Professor James Spratt. He's a CTO guru, well-known CTO master, and he just was very, I felt he was a bit uncomfortable with the statement that there was no revascularization option in this patient. And I think that it is lacking in this case. And a second question, if this patient will develop some angina in his further life, would you still consider any coronary intervention, or you expect that reducer will help him for life?
So I will answer the second one first. So I expect that it will be a relief for the rest of my life. The first question, I'm also an operator. I'm not famous like you, but I'm also in a CTO club. But no, really, the right coronary artery is small, and we don't clearly see the distal part of the right coronary artery. And we did a lot, 30 years of fighting with these coronary arteries. So in this case, really, the reducer was the solution for him, and I'm very happy because he's now still asymptomatic.
And the first question?
The first question was about the CTO.
Oh, the CTO. Thank you so much.
In my opinion, but maybe there are other answers. But it was not possible to do the CTO because we cannot see clearly the distal part of the right, and the right was very small, and I like also performing CTO cases.
Thank you very much.
I think the broader point, though, that you're making is well made, in that the context of the decision making needs to be with the appropriate people in the room. I think that's absolutely correct, that having CTO expertise, which obviously Hakim does in this case, is the right call to make before you say no revascularization is possible. I think also the broader point is that this gentleman's journey is pretty typical, and it's a revasc journey, whereas our perspective as interventional cardiologists, we think what we do is definitive. it's a full stop. Everything's a full stop. And that's not the typical history of coronary artery disease. Actually, if you have an infarct or a procedure in 1984, you're going to have a further procedure, no matter how good our medical therapy is. And we just don't seem to have woken up to that fact. We don't, even in our MDT discussions with our surgeons, they think their therapy lasts forever. We think our therapy lasts forever. The sad news is nothing lasts forever.
And you saw that the LDL, which is very important when you have a huge coronary artery disease, was low. So that's a very important point also.
So you want to...
The mechanism of the sinus.
So maybe we will see that after. After.
So Tommaso, you want to no?
No, okay. I just wanted to reiterate what James said. Actually, I totally agree. It's a matter of local availability of capacities. Of course, if you have a CTO guru, then of course you might want to choose the CTO. It's a matter of risk for the individual patient and individual lesion and procedure. And then it's a matter of what the goal is with this patient. If the goal is improving his symptoms, then as I showed you, the delta is more or less the same. Yeah, and a reducer implantation takes half an hour, and it's an easy and mostly, or basically, atraumatic choice. Yeah.
So just a question to Hakim. So how does it takes to learn this technique? It is a long...
I would say with the 5 cases with a proctor, you will be able to implant yourself this device.
And there is what kind of complication may occur during
First of all, the very low rate of complication. We have a registry in French, and we saw that the rate of complication is very, very low. And I saw some distal dissection of the sinus without any consequences, clinical consequences of this complication.
So there is a question from the audience, from Jan Schofield, who asks, it is a place after to put a lead for CRT inside.
We are in competition with rhythmologists, but if you have a lead, inside the coronary sinus, first of all, you can put the device. And the second point, if you need to put a new lead, then you will be able to open the device to put the lead. And maybe to re-put, I don't know that, maybe to re-put another reducer.
Okay, if there is no more question, so yes, okay. So go to the micro, please.
What are the main causes of coronary sinus reducer embolization? There were 2 cases in the ORPSA trial out of 26 patients, so it seems like quite a common instance, isn't it?
Two criteria are very important. The pressure in the coronary sinus, that's why we measure the pressure first, and when the pressure is more than 15 millimeter of mercury, we are not allowed to put this device. And the second point, and the main point, is the diameter of the coronary sinus. And for the procedure, you have to implant this device with the oversizing of 10 to 20%. That's also a very important thing.
Last question?
Yeah. Thank you for great talks. Regarding the indication on patients with microvascular angina, even though there is some evidence, do we have strong evidence to recommend a reducer by now? Or should we wait because it impacts reimbursement issues? The second question I have is, I experience, in my practice, I experience resistance mainly from PCI operators and cardiac surgeons. They, as the chairperson nicely said it in the beginning, you know, they don't want to see this patient. Many of us don't want to see these patients again. So what should we do to in your opinion, to raise awareness and among our colleagues? Thank you.
So for the first question, we will have answers in the next talk, and for the second one, of course, we do our best in each step of the treatment, but as we saw in the first talk, that we have patients with a refractory angina, and today, the best way to treat them with the optimal medical therapy is to put a reducer.